If you're gearing up for your pediatric ATI exam, you are in the exact right spot. We're about to do a super fast rundown of pediatric integumentary disorders, hitting just the absolute must-know stuff you'll need on test day. Okay, let's just jump right in. We all know the PEDS ATI can feel like a monster, but here's the thing. The skin questions are actually really predictable if you know what to look for. So we're going to break down infections, rashes, and burns, and we're only going to focus on that critical info you need to get the right answer. So first things first, we're tackling the invaders. The bacteria and little critters that cause some of the most common skin problems in kids. This is all about recognizing those classic signs and knowing exactly what to do right away. Okay, impetigo. There is one phrase on this slide you absolutely have to burn into your memory. Honey-colored crusts. Seriously, if you see that in a test question, your brain should immediately just yell impetigo. It's the staph infection that starts as a red spot, blisters up, then pops and leaves that classic telltale crust. And of course, it's itchy and spreads like crazy with direct contact.
So what are you going to do about it?
Well, your plan has two main goals: treat it and stop it from spreading. Top priority is usually a topical ointment like mupirocin or maybe oral antibiotics if it's a really bad case. But your biggest job? It's education. Hand hygiene is completely non-negotiable. You've got to teach the family not to share towels, not to share linens, and to wash everything separately in hot water. Containment is the name of the game here.
Let's move on to the next critter, the scabies mite. For this one, two things should set off alarm bells in your head. Number one, intense itching that gets way worse at night. And number two, these thin, pencil-like marks on the skin. Those are actually the mite's burrows. You'll find them a lot between the fingers and in body folds. And just remember, for babies, it can look a little different. You might see pimples on their trunk or even blisters on their palms and soles.
And now for head lice. You got to think of this as a multi-front war. Treating the kid is only half the battle. Step one, of course, is the medicated shampoo. Step two is that tedious job of combing out all the nits. But for your ATI, steps 3, 4, and 5 are just as important. You have to decontaminate the whole environment. That means washing linens in hot water, sealing anything you can't wash in a plastic bag for 2 weeks, and boiling or soaking combs and brushes.
All right, let's switch gears. We've talked about the invaders from the outside, so now let's talk about reactions from the inside. This next part covers dermatitis and acne. So we're moving away from contagious stuff and more into inflammation and irritation.
This right here is a classic ATI setup, right? They love to make you compare and contrast. So for diaper dermatitis, think external irritants. It looks like a bright red rash, and your priority is to keep that area clean, dry, and slap on a barrier cream like zinc oxide. Atopic dermatitis, or eczema, is the opposite. It's an internal thing, it's inherited. The skin is super dry and rough, and in little ones, you get those weeping, oozing spots. So the priority care is also the opposite. You need to hydrate the skin and then seal that moisture in.
So how do we manage that eczema? The plan is pretty straightforward. A tepid bath, not too hot, adds moisture. But the absolute crucial step, the one they will totally test you on, is applying that emollient within 3 minutes of potting the skin dry. That's how you trap the water in the skin. Everything else is about preventing more irritation and scratching. Soft cotton clothes, stay away from triggers like wool, and keep those little fingernails clipped short.
When it comes to acne medications, it's all about the patient teaching. For tretinoin, the key word is photosensitivity. They need to put it on at night and be religious about using sunscreen. For benzoyl peroxide, the fun fact is that it can bleach their towels and pillowcases, but not their skin. You gotta warn them. And then there's the big one, isotretinoin. You have to know the serious risks. It needs liver function monitoring, and it is a major teratogen, meaning effective birth control is an absolute, non-negotiable requirement.
Okay, let's move into our last section, and it's a really critical one: pediatric burns. Any questions you get on the ATI about this topic are going to be all about safety, priorities, and spotting those life-threatening problems.
Listen, if you forget everything else about major burns, please remember this. The answer is always the ABCs. Airway is first. Check for any signs of inhalation injury, listen to their lungs. Then, circulation. And in the world of burns, circulation means massive fluid shifts, so you have to get a large bore IV in and start fluid resuscitation immediately. This comes before everything else.
So you're pumping in all those fluids. How do you actually know if it's working? Well, this number is your guide. For any kid under 30 kilos, you're adjusting those IV fluids to keep their urine output at a bare minimum of 1 milliliter per kilogram per hour. That is your most direct way to see if their organs are getting enough perfusion, and it's a super testable fact.
You've got to be able to classify burns quickly. First degree is easy. It's like a sunburn, red and painful. Second degree is the one with the big visual clue. Blisters. It's incredibly painful. Now here's the part that feels backwards. The deeper the burn, the less pain. Third and fourth degree burns are often painless right in the center, and that's because the nerve endings have been completely destroyed. The skin will look leathery, black, or even charred.
So once your patient is stable, your care shifts to these 4 main areas. Pain control is huge, especially before something awful like a dressing change. We're talking IV morphine. Infection prevention is massive because burned skin has no defense. That's why you'll even restrict plants and flowers from the room. Nutrition is vital. Their metabolism is in overdrive, so they need tons of protein and calories. And finally, mobility. You have to be doing range of motion to prevent crippling contractures.
All right, deep breath. Let's do a final, super fast review. If your exam is tomorrow, this is the stuff you want echoing in your head as you walk in.
Impetigo. You see honey-colored crusts. You immediately think, prevent spreading. That's it.
Scabies. Think pencil-like marks and that crazy itching that gets worse at night. That's your diagnosis, right there.
Atopic dermatitis, or eczema, is a hydration game. Tepid bath, then immediately seal in that moisture with an emollient, and only soft cotton clothing.
And for major burns, it is always the ABCs. Nothing, and I mean nothing, is more important than securing the airway and starting aggressive IV fluids to fight off shock.
And this is just so important to understand. A major burn isn't just a skin injury. It is a full-body crisis. You have this massive inflammatory response that leads straight to shock. That's why your first moves, airway and fluids, are the most important things you will do for that patient.
So I'm going to leave you with this final thought. It doesn't matter if it's a scratch from eczema, a lesion from impetigo, or a terrible burn. Any break in that skin barrier opens up a door. So what is your #1 ongoing risk assessment for every single one of these conditions? It's always the risk for a secondary infection.
And that's our lightning review of Pediatric Integumentary. You have the key facts. Go into that exam with confidence. Good luck. You've totally got this.